the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Listeners, welcome today Nick Patterson, PharmD. Nick recently gave a lecture at our Phoenix meeting titled Postoperative Pain Management. Nick, thanks for being on our podcast.
Thank you for having me.
Let's talk about Neurontin and Lyrica, the gabapentinoids. Nick, how do these work? What makes them effective, and which one do you like better?
This is a fight I have with my PA that does pain management in clinic all the time. So the gabapentinoids work at alpha-2 ligand receptors in the brain. Essentially what they do is they work around the whole GABA, which is the gabapentin pregabalin names, or what they do. Basically calm down nerve responses. Originally, they were developed as anti-epileptic medications because they slow down nerve impulses in the brain. And what they found is that, nerve impulses don't just happen in the brain. For people who have neuropathic pain, they have a huge generation of nerve impulses up and down the nerve fiber itself, and using gabapentin pregabalin will decrease those, which is the genesis of where that came from. Now, which one do I like better? The joke between me and my pain management PA, he kept asking me, why do you dose gabapentin all the time? And my answer succinctly was because I don't have a DEA number. I can't prescribe pregabalin, which is a class 5 in the government system. Now that I have a DEA number, I can confidently say that I like Lyrica better. And there's really no head-to-head trials saying one is better than the other for postoperative pain. There isn't. What I like about pregabalin, the ease of dosing, the length of activity for the medication, and anytime that you can take somebody down from taking gabapentin 3 or 4 times a day to taking Lyrica twice a day, then you're going to increase compliance significantly at that point.
I have my favorite type of steroid too. I like triamcinolone over celestone or whatever, and I just think it works better. I just feel like patients seem like they do better with it. But anyways, I get it. I know what you're saying.
Have you tried Zilretta yet for your
I,
IV injections?
I actually have. I'm not sure if we're using it because of costs. Yeah, but we were using it some. Yeah, that has a slow release, kind of little delayed release, microscopic things in
It
it. But
doesn't dissipate out of the joint.
yeah.
Another part I want to tell people is that if
Sure.
you are going to be changing from gabapentin to pregabalin, remember it's a 6-to-1 ratio. Somebody's taking 300 milligrams of gabapentin, 50 milligrams of pregabalin. If they're taking 1,800 milligrams a day of gabapentin, you can just pretty much move them to 300 milligrams of pregabalin. A good 6-to-1 ratio between gabapentin and pregabalin works for just transitioning the dose, especially if you have somebody who is on 1,800 milligrams a day and they're like, I cannot take that midday dose. It is just too hard to do it. They can transition straight over to 150 BID of Lyrica and be doing pretty good with them then.
Got it. What about renal considerations with these meds? What kind of renal considerations do we have?
So renal consideration, anytime that you have a creatinine clearance less than 50, you're going to have to look at renal adjustments with these medications. Pregabalin I like better because you can go all the way down to 30 before you really need to make any changes. But gabapentin is going to have a hard and fast rule about 50. And this is most important in your elderly population, your geriatrics, which are going to be much more sensitive to those somnolent effects from the medication.
Okay, let's go to ketamine. You talked about how much you like ketamine, and this is from your presentation.
So I love ketamine because in the way it works completely different than opioid agonists anyway. Instead of just focus on that mu opioid receptor that can cause respiratory depression, ketamine focuses on the NMDA receptor as an antagonist, which is great if you have anybody as well who has breathing difficulties because it does not suppress the respiratory drive, as well as the way ketamine interacts with that NMDA receptor is a long-term effect. It's not something short. That's why in some of these pain clinics, or what we call the ketamine clinics out there, somebody can come in and get a ketamine infusion and get one done every 2 weeks or every month, and it can control the pain for up to 2 weeks. Ketamine alters the way that receptor responds and puts out any kind of pain signals. And ketamine isn't the only one that does that. We've got small clinical trials where magnesium infusions during surgery can do this as well. So it's all about hitting pain from multiple different receptors out there. Now, the problem with ketamine is, I think it's everybody's biggest fear is, what if you drop into a K-hole?
K-hole? Tell me about a K-hole.
So K-hole is when you give too much ketamine and cause them to go in a completely dissociative state. You will see it in, I think the best portrayal of it, it's been in a lot of horror movies where they drug somebody with ketamine, but it does end up happening when you go to the highest doses of ketamine, and you'll get pretty much just a stare and nothing else. You get pretty much a non-responsive person. But when they come out of that, that's where you have your hypertensive, almost urgency. You have somebody who is combative and they don't know exactly what's going on. That's always been the fear with ketamine.
Okay. And then you also talked about when someone wakes up from ketamine, and I've actually seen this in the ED. I have
Yes.
not seen this at clinic or, and to my knowledge, I don't know, I don't, with the anesthesia, that's kind of, they do the meds and, so I
Mhm.
don't know. But yeah, tell us about what happens sometimes when people wake up from that.
They will wake up being it's almost like a delirium when they wake up. I won't say it's delirium because that's a completely different diagnosis, but when they come out of it, they don't know what just happened. They don't know what's going on. They're scared and they don't understand the surroundings around them. And that causes that fear response. And you have to a lot of times hold them down in bed when they're coming out of it. Now, not everybody's going to be that combative. A lot of people just have increases in heart rate, increases in blood pressure, and a lot of times they end up giving excess opioids in order to control that response.
One question I had when I was reviewing your presentation was the short duration of action of ketamine. How does it work that it lasts longer? Maybe you already said this and I just missed it, but how does it work for postoperative pain with a short duration of action?
Okay, so the way it works, whenever you alter that NMDA receptor and it's not able to generate a pain response, you don't get a hyperalgesia of the receptor. So essentially, you're stopping the nerve impulses themselves from getting very sensitive to what's going on with the pain. And once you stop that from occurring, you stop that signal going back and forth as much as possible. Essentially, what it does is if you stop the generation of that response from the NMDA receptor, similar to how methadone works, and similar to also how dextromethorphan works, then it cannot set up that sensitivity of the receptor or in the pain area.
You had mentioned IV lidocaine. You don't really think it's effective, so I didn't really want to spend a lot of time on that. Do you have any comments on it?
No, we're just waiting for more data to come out on it. First of all, we thought it was going to be effective, but what ended up happening is the data overall in the trials, and they only studied it really in abdominal pain or post abdominal surgeries, and the data was conflicting at that point. So we're just waiting for more data out there. Now, personally, I've known multiple people, especially GI docs, that have used it and had really good results with it. Especially in the younger population, it seems to be relatively safe. It just doesn't have the data out there to support it from Cochrane database or anything else.
You had also just a little bit ago mentioned IV magnesium sulfate, and it's similar to ketamine without the hallucinations, so without the,
Hmm.
dissociation or that kind of stuff.
Hmm.
When would it be a good option for postoperative pain for orthopedic stuff?
Anytime you have somebody who has a history of either poor pain control post surgical or somebody who has a contraindication or an intolerance to ketamine would be a good place for this. The person has to have healthy kidneys to start with because if not, you can start to have excess magnesium in the body, which can cause effects as well. But usually, you have somebody who has poor postoperative pain control, doesn't tolerate ketamine, or potentially somebody who has been on long term opiates as well, which
Gotcha.
usually means you have harder pain control post surgical.
And I have to say, when I see IV lidocaine, IV magnesium sulfate, I'm thinking ACLS. So any like cardiac issues or anything you have to think about when you're administering these meds?
Yeah, that's one of the big ones. Making sure you have and I don't know, do you guys still send people out to get a general medicine release before you do surgery on them?
No, it's usually me or a
Okay.
colleague of mine that fills out a paperwork and the 5-minute physical exam. Breathe in and out, the stethoscope on one spot, breathe in and out. Okay, yeah, your heart's beating good. So, yeah,
Listen to the triple point.
exactly. Yeah, but that being said, I'm being a little bit funny, but we do have, if somebody has issues, we do get medical clearance, cardiac
Okay.
clearance or whatever. Yeah.
And a couple of things to look for when you're going through their meds. Are they on beta blockers like atenolol or metoprolol? Calcium channel blockers, specifically diltiazem or verapamil, If they have any history of an SVT, a supraventricular tachycardia, or an atrial fibrillation, those people you definitely wouldn't want to use lidocaine in because there could be a chance of causing an arrhythmia. Those are the people that I'd be most worried about using lidocaine in.
Got it. Listeners, please stay tuned next week for part 3 of our discussion with Nick Patterson, clinical pharmacy practitioner. We're having a discussion about postoperative pain management, and we're going to cover some opioids and alpha 2 agonists. Thank you for joining the OrthoPAC podcast. Please follow the physician assistants in orthopedic surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.